I'd like to offer an overview and summary of my experience and some suggestions to do with health and social care in relation to the patient journey. If I can start off by talking generally about the patient pathway and share with you something that I wrote some time ago. The patient pathway may involve attending appointments, undergoing tests, scans, surgery, being a hospital inpatient, being discharged, remaining an outpatient, and so on. It may also involve some significant life changes. The journey can be a long, tiring one. The patient is the one common denominator. In terms of looking at this sort of disjointed pathway, I would say that there are many different professionals who play an important part in the patient's journey. From what I've experienced and observed, the majority of professionals do an extremely good job in their own area of expertise. People can, however, appear constrained by their own systems, areas of duties, etc., working in quite isolated boxes in fulfilling their own duties. However, the patient's journey is not a set of separate areas but a continuous path. It is the gaps between where one system ends and another starts without some sort of handover that can cause problems for the patient. As it stands, the patient journey can appear like a set of disjointed stepping stones rather than a smooth path to follow. In terms of gaps, further to leaving an appointment with my consultant, I once found myself very quickly in a gap. The gap I experienced was between being an outpatient and waiting to be admitted to hospital. At this point, I had no access to professionals, no signposts, no contact numbers, only impersonal general switchboard numbers. I'd say with this that being a patient, it's not general, it's extremely personal. At this point I seem to have gone off the radar altogether. So again, in relation to my personal experience, further to my diagnosis of needing surgery, I was suffering from deteriorating health while waiting to be admitted to hospital. Community services were not informed of my position. Living alone, I was left totally isolated as there had been no communication between the two areas of health and social care. I would ask at this stage where the responsibility lay. In terms of access to services, the responsibility fell to me as a patient who was ill and under tremendous pressure already due to ill health, etc. Poor health meant that I was frequently unable, physically or mentally, to make phone calls, retain information, or attend appointments. I was not assisted or empowered to access help. It was like being on some sort of invisible offshoot of this pathway. I had tremendous difficulty attending hospital appointments. Ambulances, etc. have to be booked in advance, but my condition does not give me advance notice of my ability to physically get out of bed, walk or attend appointments. As I can't afford to miss hospital appointments because of delaying treatment, I once nearly had to turn up in outpatients in my nightwear being physically sick. This will do little for a patient's dignity or self-respect. In terms of communication from professional staff can have a very important impact on the patient, as the patient tends to trust their care and well-being to them. Further to their own appointments, professionals hold meetings and decisions may be made concerning the patient. If this is not communicated back through regular updates, phone calls, letters, etc., giving reasons or explanations for changes to the patient, they can feel insignificant, powerless and a victim of events. Keeping patients informed could be a relatively simple procedure compared to the high level complex discussions being held on behalf of the patient. Neglecting the follow-up, however, can cause significant yet unnecessary damage between the doctor and the patient. When situations are simply explained, it makes a huge difference. For example, appointments may have been overbooked. People may not like to admit mistakes, but I think that the vast majority of patients find it easier to accept and understand that things have happened which have delayed appointments. And when they're told, rather than becoming angry, it stops frustration and resentments and bigger problems actually growing. Keeping people informed of changes, delays, etc. shows courtesy and respect. Also, in many situations, there are very genuine, acceptable reasons for it. In dealing with any major life event, it is important that an individual is psychologically and emotionally strong and focused. If the patient awaiting treatment is allowed to weaken through an onslaught of emotions, fear, anxiety, frustration, isolation, it does little to enhance their physical survival and recovery chances. In terms of suggestions, I believe that health and social care staff do work towards the best interest of the patient and the patient's care being paramount. I also think that every professional should focus on what they do and their particular area of expertise. However, I do feel there is much scope for additional patient support. For example, what happens to the patient when they come out of a medical consultation, when they walk out of a scan? Is there any support for them there? The patient journey tends to be looked at by many people. I don't think a patient would expect to be part of any specialist medical or service provider group, and yet patient groups are often composed of professionals. The input of patients regarding this journey often appears to be considered incidental, a bonus, sometimes interesting, and yet it is their very journey that is the issue. This can be difficult because of the physical, emotional, psychological stages the patient is going through. I would, however, suggest that there is a need for stronger links and communication between hospital and community care so that such gaps don't exist. For example, direct links between hospital and community service further to a patient receiving a diagnosis. This would avoid the patient being left in a gap. Communication between services would alleviate the need for crisis management. For example, calls to the emergency duty team, patients being left unattended and at risk. Also, communication with patients, giving reasons, explanations, and keeping patients informed can be very beneficial. Handovers between services may offer greater accountability and responsibility, enabling service users to be clear about who to contact. I would suggest that sometimes complex physical surgery could be further incorporated with adequate psychological and emotional support. Physical survival alone is rarely enough to maintain a patient's well-being. Consider, when does a patient become a client along this path? As an individual's status doesn't change along this pathway, they're still always on the same patient